And I will present just one of the standards, and that's, I think, the most important. It's called Family Access. But in the future, we will re-edit, and we will call it Zero Separation and Couplet Care, maybe. But also, as she pointed out, and she has been enormously successful in making this a global perspective. I'm extremely impressed by all your contacts globally. I will touch on that. But here is our group, the Infant and Family Centered Developmental Care Group. And Pierre Kuhn is the co-chair of this group, and you can see all these members from all countries. Several disciplines, physical therapists, occupational therapists, nurses, of course, neonatologists, and psychologists. And we will hear from many of them today. In my presentation, I would like to talk a little bit about terminology. Developmental care, Silke mentioned, was actually the first term that was mentioned originally. And then people started to talk about family-centered care, and then later on we had patient and family-centered care, where you put the patient in the center, not only the family. So this is the next thing that I've heard about, and we'll hear something about, is family integrated care, and we will not cover that much because it's actually a program and not a generic term as the other terms. And family participatory care is something that they have coined in India, and I will come back to that later. But in our group, we actually quite quickly decided on this terminology. We thought that this was, all the different professionals thought that this was the best way to call it, to frame it. Infant and family-centered developmental care. And of course, developmental is very important to have in this concept. I'll come back to that. Now it started up in Europe, and it has been accepted also in the United States. We will hear that from Joy Brown at the end of the day, or in the morning in her place where she's in the US, and it's also now getting globally by the GLANCE initiative. So what is the IFCDC? As I said, it's a generic term of nurturing care of the newborn, with goal to ensure best health and development into adulthood for every individual infant by optimizing both individual care, hospital systems, and it's founded on the leading edge work of Barry Brazelton and Heidi Lisals. They were the pioneers in this area, I must say. And also, of course, founded on the Declaration of Infants' Rights, developed by the WAIM in 2016. IFCDC is easy to remember because CDC is something you talk about these days, don't you? And just add IF in front of it. IFCDC is evidence-based. The science of neurobehavior, neurodevelopment, parent-infant interaction, psychology, parent involvement, nursing science, breastfeeding promotion, we heard about that, environmental and systems adaptation, very, very, very important. We say IFCD had three core principles, and it's sensitive, responsive caregiving or parenting based on the behavioral communication of the infant is essential foundation for the child development. This is self-evident for older children, but it actually definitely applies even more important for our immature babies. The third principle, that parents' engagement promotes, of course, parental well-being and parent-infant relationship, and thus child development. And finally, it's an individualized care. It gives the baby a voice of its own. So remember, this is a generic concept. Several programs try to address these things, but some of them more completely than others. So this is the IFCDC. We have the different standards. We mentioned zero separation, talk about that today. Continuous skin to skin, not so much today. parental-infant bonding we'll hear about, parental involvement, we'll hear about sensory environment also, we'll hear about supportive services, something, and case management also we'll hear today later, and clinical consultations and supervisions for healthcare professionals we will hear Sari talk about that later. And education and training may be very important, maybe the most important, or not the most, extremely important topic. So I often use this picture that Heidi Als made 1992, but I think it's very useful to have the systems thinking of the infant system, parent system, family system, NICU system, hospital system, and community systems. And of course, you all know that it's so much happening in the brain of the infants. That's why the developmental part during the care is extremely important to underscore. You need to have the competence to observe the infant, how to interpret the behavior of the infant, and how to support it during painful procedures, for example, and to promote by co-regulation, to promote the baby's self-regulation. The baby is regulating you, the caregivers, the parent, and you regulate the baby. It's a co-regulation. That's extremely important. And that enables for social interaction and parental bonding and infant attachment if you can help this self-regulation of the baby. Also, I don't need to go into the standards format and template because Silke did it so well, so I just skip those slides. I go directly into the zero separation issue. And we have these, I'll show you a set of slides from Stockholm, Sweden. And you can see here slides where we keep the baby as much as possible together with the mother and father, even if we need to do caregiving at the same time. It's extremely important. You can see these parents, they don't know what we are doing, but we know what we are doing. We have the equipment, we have the monitoring, we have the gases and everything. And also after C-section, we are very keen on keeping contact with the mother as much as possible. And in this case, unfortunately, the mother needed intensive care of her own, so she couldn't come into the NICU for a couple of days, but the father was there, skin to skin with the baby. Breastfeeding, Silke covered. So I think she was completely right to emphasize this as a very important standard. Virtually all mothers can breastfeed if, as she pointed out, if she gets support and information about breastfeeding. But also very important, we need to start very early, not only with expression, but also giving this half milliliter or milliliter of manually expressed breast milk to the infant as soon as possible by a syringe in the mouth. It's doable. And in a global perspective, of course, exclusive breastfeeding should be done up to the first 6 months at least. It's for survival purposes. So we need to support the breastfeeding. But couplet care, it's the sort of top notch of family of IFCDs, I would say. Couplet care, in this concept, it means that you from the very start are coupling the care of the baby with the care of the mother, the medical care of the mother in the NICU, in the same ward. And of course, you all know that maybe 30, 40, 50, 60% of the mothers that give preterm birth do it by C-section. Or other they might have this hypertension, diabetes, and whatever, preeclampsia. So they definitely, the majority, I would say, have medical needs of themselves. So that's why you need to try to couple the care in order to avoid separation. Twin mother, diabetes, C-section in week 31. Midwife or postnatal nurse checking the uterus in the mother in the NICU. And our experience and research has shown that it reduces the total length of stay, especially during the most intensive care period, which is also the most expensive care period. It reduces the incidence of lung morbidity, reduces mothers' anxiety and boosts their feelings of competence and as a parent. It improves and attunes the mother's infant stress regulation, and it enhances breastfeeding. 3 months post-discharge, we have some unpublished data from the Stockholm trial. But of course, sometimes the mothers are too sick. And the exclusion criteria for couplet care would be severe preeclampsia, or eclampsia, of course. And also if the mother has had a large bleed or other hemodynamic instability, other reasons for intensive care of the mother. So we don't propagate intensive care for the mother in the NICU yet, at least. Maybe in 10 years, we don't know. And of course, if she has contagious diseases, we have to take some extra consideration, precautions. And also if she has severe psychiatric illness. But then, of course, often the father or a relative can be present. I will not talk so much about the NICU design, but of course, you have to redesign your NICUs if you will be able to do couplet care. Just one slide. I think that sorry, it was Stina that texted me a message, but I read it afterwards. She can talk with me aloud if she wants. Anyway, at Karolinska, we have the experience of having one area where we have the most intensive care with mechanical ventilation, chest drains, and these hundreds of IV lines in one area where we have space for the mothers to have a decliner or a bed, but we don't expect them to sleep in this area because it's so taxing for them. We have family rooms in a suite model adjacent to the intensive care area or a few steps away in the corridor. And remember, the family rooms need to have their own bathrooms, showers and toilets. And if you have couplet care, you need to provide big bathrooms for the sick mothers. So that's one thing that I want to point out. But as for the global perspective, it's very important to remember that you see the size of these circles, the pie diagrams, represent the numbers of infants born preterm in the world. Approximately 20 million infants born every year that are either preterm or very low birth rates. And most of these infants are born in this area of the world, of course. You can also see, and the high-income countries are the yellow countries, and they are very much less. And also you can see that the sector of babies that die are proportionally much larger in these countries, of course, and also the ones that have severe impairments or mild, moderate impairments. So it's very important to have this global perspective. Also interesting to note is that the daily risk of death for a newborn infant in general, during the first 28 days, is actually occurring especially in the first 24 hours. So 50% of the neonatal death occurs within the first day, and then 2/3 within the first 3 days. So, and 70% of all neonatal deaths are attributed to preterm or very low birth weight infants. So we need to concentrate on those infants if we want to increase the survival of children in the world. And also remember now, note this, that most infants die before they are considered stable. That's before they are eligible for the current WHO recommendation for kangaroo care or skin-to-skin contact. So the previous studies have been done on stable infants. This has caught attention, of course, to the WHO, and I would like to highlight Rajiv Bal. He is the lead of research and guidelines in the Department of Maternal, Newborn, Child and Adolescent Health at the WHO. Very important person in the World Health Organization, I would say. And I borrow some slides from him now. Kangaroo mother care, initiated in hospitals, has been shown already that it improves survival by 40% and reduces the nosocomial infection by 55%. But even if we have this knowledge, we have not been able to decrease the mortality that much. So the WHO has identified knowledge gaps. Is KMC equally effective if initiated at home for stable infants, or immediately afterwards without waiting for the babies to become stable? Would that increase the efficiency? And they have just concluded a large community-initiated KMC trial in India, and I will talk shortly about that. The population that studied was babies that are in many countries are actually discharged as soon as they become stable, from 1,500 grams to 50 grams. That was the population studied. The intervention was KMC initiated within 24 hours, either in the hospital, not often, but after discharging, so that it was actually often community initiated, because the babies were discharged before they were trained in KMC in the hospital. And it was continued at home and supported at home. The control group was conventional existing care. And the outcome was mortality in the first 28 days, neonatal mortality, and mortality during the first half year. And it was studied in the poorer district of India. And the sample size was the impressive 8,000 babies, published in the Lancet last fall. And here you can see that the mortality, the 28-day mortality, was significantly lower in the intervention group as compared to the control group. And also, if you followed it at 6 months of age, it was even more larger difference. It's very, very interesting to see. It seems to be continuing the difference that is increasing between the two groups. They could demonstrate more breastfeeding here in this group, and also better growth. So that's probably one of the reasons, and lower infections. So very important with community-initiated KMC for low birth weight infants. But what the other question was, immediate KMC. This was a study that Nils Bergman and Barack Morgan and I have been planning for many, many years, and it took us about 8-9 years before we could convince Melinda Gates Foundation to support us. And then we're very happy that WHO is now taking over the study, and they are actually the sponsor, the organizer, coordinator of the study. We randomize is a RCT in referral hospitals, not in the other study, small birthplaces. This is academic centers, referral hospitals in Ghana, India, Malawi, Nigeria, and Tanzania. We chose that because it's an efficacy study. We wanted to test if it could be effective on under the best circumstances. The sample size moderately 4,200 mother-baby dyads, and the birth weight here, we addressed the smaller proportion, 1,000 to 1,800 grams. We couldn't have larger babies because they were discharged too early. The intervention was KMC, or skin-to-skin contact, initiated as soon as possible after birth and continues beyond the mother, or beyond by the mother or a surrogate. I'll come back to that later. The control group got their KMC according to the current WH guideline. After they had become clinical stable, they got the KMC. Outcomes were mortality, clinical sepsis, hypothermia, hypoglycemia, and also 2 years out developmental outcome we will cover. And shortly, it's small infants, mostly preterm, considerable number of twins, considerable number of C-section babies, some were asphyxiated, at least moderately, hypothermia babies, and we have RDS in 30%. And here's preliminary data that the skin-to-skin contact during the NICU stay was in average around 18 hours per day, mostly by the mother, but also by surrogates. In the study, we also provided for both groups, both the control group and the intervention group, CPAP systems. They were based on electric oxygen concentrators. no gases in pipes, electrical concentrators, and we used the original bubble prongs, easy to clean, good, easy to maintain. And we also provided saturation monitors. For the intervention group, we trained, and for both groups, we trained for minimum package of care so that we raised the standard of care in all these hospitals. But also we taught about the skin-to-skin contact, in safe skin-to-skin contact, highlighting, underscoring secured airways, and also breastfeeding supports for both groups. But the initiation of skin-to-skin was different. Also extremely important, I don't have time to cover this, but minimum care package for mothers were also designed. And look into this later. What should the obstetricians do for vaginal deliveries, C-sections? What the staff nurses should do the first 4 hours, and after the 4 hours, how often should they check and what should they check on the mothers? These were implied to both groups, of course. Zero separation then. Some pictures this is from Tanzania, twins, 10 minutes old, around 1,300 grams, and they are suckling, aren't they? A little bit later, another baby from Tanzania, mother still on the post-op department, and this is the aunt of the baby, and very sweaty, and also the mosquito nets, of course. And this is Jill Bergman, which was our KI team, KMC and breastfeeding educator. Conventional care could look like something like this, but actually, for the study purposes, we actually provided single beds for the control babies. So this would be control babies. This is from India, and these are actually not control babies, because in these countries, 3 babies or 2 babies or 3 babies in one incubator is not uncommon at all. It's mostly the most common thing. The control infants, when they were stable enough for intermittent care, they got that even before they were discharged to the KMC wards. And just an idea how it would look like for the families. This is the family quarters in Malawi, which is outside the hospital building, but on the grounds. This is the kitchen with open fire cooking, and this is where they are eating, laundry. And these are the family supporters that take care of that. That's our sisters or mothers-in-law or mothers of the women that gave birth. Also, a fantastic picture from India. I took it in the middle of the night in December, and I saw, who are these people? These are grandmothers or aunts, supporters, family supporters that don't have a bed, but they don't leave the hospital. They just lie down on the floor outside the NICU to support the postnatal ward, to support their young female relatives. So, and this was 12 degrees Celsius. So I'm quite impressed by the commitment. But for the study purposes, we needed to provide opportunities for continuous KMC, of course. And this was the first unit open in India, Mother Neonatal ICU. It is Safar in New Delhi, India. And it would look like something like this. This unit is a 12-bed unit, and you have declining chairs quite well equipped, actually, as you can see by these beds. And one mother in each bed. That's also not so common in every country, but we provided that, one mother per bed, and also space for the surrogate. A nursing station in the middle. This is a newly delivered mother, young mother, and her mother, baby on CPAP. And this is the family kitchen, simple but efficient. And it serves 12 mothers and 12 surrogates, family members, 24 people. And they have bathrooms there as well. So here, these surrogates or mother support, family supporters, they lie on the floor as well, without beds, and they're very happy because they can stay with their with their mothers. So this is how it will look like. And of course, we need couplet care, medical rounds from the infant by the neonatal team, and also medical rounds of the mother by the obstetric team. Some pictures from Nigeria, intervention babies. This is from Ghana, the control area, quite a new unit actually. And this is the intervention area, the IKMC couplet care area. But you can see it's very, very crowded. This is from Malawi, young mother that gave birth to twins, and she got a lot of support. It's very important, common in these countries. And this is from Tanzania, also to rebuild the unit so that more space, and and these are examples of provision of respiratory support in KMC position in these countries. Of course, from the very beginning, mothers couldn't be skin to skin with CPAP because they are they need to be observed. So then the surrogates stepped in, and in Sweden it would be the father, but here in these countries there are female relatives that do that. But then when they are stable, they leave the NICU or the mother NICU and are discharged to the KMC wards in these units. So this is again colleagues and Jill Bergman supporting the families. We have, this is the planning group, this is Nils Bergman, and this is Rajeev Bal, very, very important and very enthusiastic, as you can see, testing how it would feel to have a baby, not skin to skin, but at least on these binders. And Professor Harish Shilani from New Delhi as well, and the KIT neonatologists. So what's happening with this study? Well, we, of course, in this such a large study, there is always an external monitoring team, and they are looking at what's happening with the two groups. And we plan to complete the study this summer. However, already in January, this Data Safety and Monitoring Board stopped the study because their statisticians discovered that we had actually significantly lower mortality in the intervention group, even if we had not come up to the expected numbers of the study. We don't know the details yet because we haven't had time to meet, and we cannot meet now. We were supposed to meet in a few weeks in Geneva, but of course we need to do it on Zoom now because we need to do the write-up and analysis. But very, very important result. We lowered the mortality with at least 20%. That was the cutoff. We lowered the mortality with at least 20% by this immediate intervention and breastfeeding support. And also, if talking about system change, even before these results, the Indian Ministry of Health issued already 2 years ago a recommendation how the Indian level 3 units, SNCUs, should rebuild or should remodel themselves. And of course, you can understand that it's approximately 1 million infants cared in the NICUs each year in India. And they said that the NICUs should provide developmentally supportive care. It's fantastic. And they also said, as Silke pointed out, that they should provide bed and diet and treatment for the mothers in or close to the level 3 unit, in the same building at least, or very close to. So they actually propagate for couplet care all over India. They have around 1,000 NICUs, so it will take some time. But WHO is working on this zero separation concept. And we had a meeting 2 years ago, or 1 year ago in New Delhi, in Southeast Asia region, approximately 2 billion inhabitants. And the policy taken was zero separation policy was decided to propagate on. So, well, thank you very much. That was all I had to say today. Stina, come in and guide us.
Yes, thank you, Björn. That was fantastic, as always.